next person I'd like to introduce is Tom Rapisardo. Tom Rapisardo is clinical assistant professor at the University of North Carolina at Chapel Hill. He's a member of the clinical staff of the Department of Supportive Oncology and sees patients in our Cancer Survivorship Medical Clinic and our Senior Oncology Clinic. Dr. Rapisardo's clinical interests are follow-up of cancer patients and assessing potential late effects from cancer treatments. I've known Tom for a long time. In fact, he truly is one of the best doctors I've ever come across in my more than 20 years of taking care of patients. So I'll turn it over to Dr. Rapisardo, and he'll talk to you about survivorship. Tom?
Well, thank you, Richard. That was cause for me to be humble. I appreciate that a lot. I really wanted to thank everybody, for allowing me to spend some time introducing the concept of survivorship. I want to thank everyone who's viewing this for taking time to get more information, staying abreast of new developments. As Richard mentioned, my name is Tom Rapisardo. I am not an oncologist. I'm a general internist. I've had experience with being involved in following cancer patients for almost 40 years now. During this time, I was often asked by patients, what do we do now? Even if they were still being able to be followed by their oncologist. They would put the questions to me about what do I do to avoid recurrences and how do I prevent other types of cancers? There's definitely been progress in this regard. There's now access to guidelines and expert opinion that we really didn't have before. So we're going to use this to explore today using melanoma as our topic. Next slide, please. So the topic is, what about survivorship? What about planning for life beyond cancer? Next slide, please. So the incidence of melanoma has increased, but luckily, as we can tell from Dr. Amin's earlier citation of the literature, is that there's been substantial reductions in morbidity and mortality. If you look at all this, including lung cancer and melanoma, there's an article from the New York Times just this last year. This is the largest ever decline in mortality that has been seen from 2016 to 2017. Next slide, please. So what is a survivorship plan? It's basically a guide. It's a roadmap. We need to know about the past as well as the present and what the future is going to hold. Next slide, please. Next slide. Thank you. So when we talk about a survivorship plan, we have what we call the Survivorship 7. Basically, this involves surveillance and screening. We talked a little bit about genetics. But we also want to talk about general health. So we talk about people getting vaccinated up and talking about the potential late effects. And we want to make sure that they've straightened themselves out and they're living a healthier life. Probably the most important fact here is that we want to make sure that the information from their treatment is clear to them as well as to the people who take care of them. Next slide, please. When we start dealing with the treatment summary, this is actually where I spend most of my time. I need to know the details. You've heard the expression devils in the details. Well, that is absolutely true when we're talking about cancer treatment. We need to know who was the treatment team, not just their names, but where are they from, what is their contact numbers in case we have to get further information. We want to know details of treatment, including, what chemotherapy, what was the dose, when was it received, if surgery was done, what exactly was done, what's the path report, radiation, what was radiated, where, how much, all those things. Next slide, please. So when we talk about surveillance and follow-up care, next slide. Oh, we're waiting for that to load. So we're basically talking about ways to check for return of cancer. Next slide, please. Next slide.
He might be having some difficulty.
Yeah, it looks a little slow.
Are you able to continue without the next slide?
I think so. Let me bring up what I've got here. What we have basically now is actually surveillance guidelines. What we use primarily here is the National Comprehensive Cancer Network, or the NCCN guidelines for post-treatment care. These are generally evidence-based and protocol-driven, and they gain from the experience and expertise of a lot of national experts. Their particular guideline is that everyone, this should be obvious, I think, with melanoma, to get a whole body dermatologic evaluation by a dermatologist every year. We also suggest that people get dilated retinal exams at some point. The follow-up dermatologic exam is not just a eyeball type thing. You want to get someone who is boarded, probably has an interest in this, using dermoscopy and digital imaging if possible, because it just improves resolution. We want patients to get educated about their own self-exam. I spent a fair amount of time with this. We need to explain to people, geez, you had a melanoma on your forearm, it was resected, you're fine. But if you want to check your, under your elbow and under your armpit from time to time, check the regional lymph nodes, you want to make sure you do a decent self-exam. If you have a significant other, when you get out of the shower, they can kind of look at places that you can't look at. Next slide, please. Still stalling. Okay. When we talk about the specifics of what is the particular thing that you want to look at in the skin, I think this is going to actually get easier with the internet over time, because you'll be able to compare. But basically, you want to look for anything that's kind of new. It's asymmetric. It has uneven borders, different colors. You notice a new lump, especially in the lymph node distribution. Any bone pain, you're getting a cough, any discomfort in your belly. Those are things which I think people know would indicate more the metastatic component, which hopefully would not happen. Are there any persistent headaches, difficulty with speech, any kind of neurologic symptoms? Unfortunately, we don't have any simple lab tests to follow melanoma. We can look for indirect evidence on occasion, but this is hardly ever called for. Next slide, please. So the follow-up care plan, basically, we've talked about surveillance. Screening, if you've been through one cancer, you want to make sure that you don't have to worry about anything else in the wings. So when we talk about screening, we get an adult male or adult female, we talk about, well, these are the other cancers that we would want to make sure you get checked on a regular basis. And we go into some detail to make sure that that's happened. Next slide, please. I think this is another one that's going to be a delay. There we go. So when we look at which tests are recommended, for melanoma, there really aren't a lot of tests. Certainly not the case for other types of cancers. One of the things that's interesting looking at National Comprehensive Cancer Network guidelines and the European group, European Society of Oncologists, we probably over-test, actually. I think if anything, we want to do something specific that's proven, that's useful, and has information that we're going to use. Typically, how often should you get the test done? Your oncologist will tell you, or your primary care doctor can tell you. They are the ones who are typically going to order this as well. Next slide, please. So the type of screening generally that is looked at is we want to have something that is sensitive in terms of the test, that is specific and has shown utility. So when we see an adult male or female, what we look at is, what am I going to do in terms of the likelihood of particular and risk of particular cancer and the utility of a specific test? It varies somewhat. If you've had someone who's never been a smoker, not particularly worried about lung cancer. If there's some genetic history, which is important, there's much more extensive screening that happens. A general guideline would be, colon cancer. So if someone is worried about do I need to be screened? Well, yeah, you do need to be screened. Typically at age 50 for the general population, it's going to be earlier if you've had first degree relative who's had colon cancer. Next slide, please. So we talk about late onset in terms of effects of treatment. For a lot of early stage melanoma, the treatment is primarily surgical, thanks to the innovations done by surgeons like Dr. White, doing less surgery. It's much more specific. And I don't mean to say less surgery overall, but less invasive surgery. Luckily for that, there doesn't appear to be a lot of long-term residual, although lymphedema certainly can be a problem. If you develop advanced stage disease, like what Dr. Amin, her colleague, deals with, we're dealing with considerably other things that need to be monitored. One of the things that I find absolutely fascinating is just how effective the immunotherapies are. What do we need to do in terms of long-term depends upon what potential side effects occur during the treatment with the immunotherapy. Next slide, please. These are questions I would certainly have if I had a cancer. Multiple family members in my family have had cancers, and I get these kind of questions all the time from them. Next slide, please. One of the things that I've seen doing this for a lot of years is that I think almost everyone has recurrence anxiety. It may be verbalized, it may not, but it can certainly spill over into your life. Associated depression, insomnia. I can remember very vividly a patient, young man that Dr. Amin sent here who was literally cured from advanced stage melanoma, but could not enjoy the life that he had, which was really devastating to him. And luckily, with a little counseling and some treatment, he's now having a full life, which is the whole point of survivorship. The surgical residual really isn't as profound as it used to be. As Dr. Amin mentioned, not a lot of chemotherapy at this point. It's mainly immunotherapy. Are there long-term effects with immunotherapy? Not that many from what we can tell thus far, and I certainly defer to him. There are several in treatment adverse side effects which may leave some residual. We were asked specifically to address the topic of fertility. This isn't an area that I have a lot of expertise, but I did ask our experts, and they're not aware of any specific long-term issues with fertility. Next slide, please. This is probably the most important thing of what we do. We try to coordinate care to make sure that you, your doctors, everyone is in the loop. Next slide, please. You'll get to the point where you're no longer seeing an oncologist. When that occurs, your primary care provider will probably be your contact person or your first responder, in other words. The primary care doctors don't just deal with common health problems, which are certainly multiple. One of the things that we do is the bottom thing you mentioned here, screening and surveillance. They're your contact person for finding out, well, what do I do? I mean, how often should I be checked? They can hopefully be the person who would refer you to a really good dermatologist or an ophthalmologist or whatever specialist would be needed. Next slide, please. So this is a primary care provider who's obviously following his own advice. He looks incredibly healthy and vigorous. We spend a large amount of our time going over these issues, mainly because this has a lot to do with how you're going to do with the rest of your life. Dr. Greiner already spoke a lot in terms of diet and nutrition. Tobacco is a constant problem, which we work at a lot. I apologize to patients early on, but I don't like to bulldog trying to get them off tobacco. We dealt a little bit with sleep and stress, but all these things are extremely important. The other issue, we talked a little bit about genetics, but we don't get a lot of discussion about epigenetics. So the whole point of integrative medicine, and I want to thank my colleagues for educating me in this regard, is that you can deal with the genes, the switches that turn them on and off. I'll never forget a presentation that I saw where two genetically identical lab mice were shown on the screen, and they looked nothing alike because they had been given different environmental circumstances to grow. So the whole point here is that we can do a lot to switch genes on and off, not specifically talking just about melanoma here, but other cancer genes. Next slide, please. So the whole point here is that we want people to get a survivorship care plan. Basically, this is something that you want to keep. You get a lot of information nowadays when you leave the physician's office. We call it after visit stuff. That's not actually what we call it, but it's usually pitched in the trash cans. We even see them in the waiting room sometimes. But this is a document. When it's sent to you, you want to keep this, and you want to make sure that you communicate the guidelines to the primary care provider. I make a point of making sure that all the primary care providers get everything that I have. Next slide, please. I wanted to talk a little bit about, for those of you who are do-it-yourselfers, how you can look at providing your own survivorship care plan. Next slide, please. So basically, this kind of gets into the treatment summary, and you can see the details that we're interested in, which are multiple. Next slide, please. This again, it gets into the type of drugs, the surgeries, the radiation. Next slide, please. Symptoms, you want to be as specific as possible and be general as well. I mean, if there's anything you think may be related, please mention it. Next slide, please. In terms of the care plan, we again discussed lifestyle change. I don't know if it's apropos, but I'll mention that one of the reading material that I received from my integrative colleagues was a book called Anti-Cancer, which I found to be fascinating read. It goes into a lot of this information and the evidence behind it, which sometimes is a little dry, but the guts of the book is about 15 laminated pages, which anybody can look at, and you get the gist of what the guidelines are. Next slide, please. Again, with the care plan, these are all the late onset side effects, and it kind of helps you articulate exactly how you're affected by this. Next slide, please. Surveillance, this gets into the specifics, because what you want to be asking your provider is that, okay, how often do I need to get checked? Well, it depends. If you have a lot of small pigmented nevi, which are not cancerous, but we worry about those, I'm going to suggest that you see a dermatologist on a regular basis, probably every 6 months, at least initially. If you've had an isolated melanoma and you don't see any skin lesions, probably once a year is fine. Next slide, please. Cool graphics. I wish I could say that I did that, but it was my nurse manager who did this. So the whole point here is that health is multidimensional. It includes mind, body, and spirit. You've been through incredibly traumatic times, and we want you to be able to enjoy and live your life fully afterwards. It's important to realize that your ongoing health, in terms of preventing problems, is extremely important. The survivorship care plan is something not to be pitched. It takes a lot of work. It's going to be very useful. We have an incredibly mobile society, at least we were pre-COVID. I think there was a Gallup poll that said literally 20% of the population moves about every 4 to 5 years. If not that, then what happens is you change your insurance provider. Many different providers don't share the same electronic medical records, so it's really useful to be able to have records. It's almost like passing notes back in grade school, but it's useful. The survivorship care plan, we kind of talked about what's in that, and there are many other resources which I'm going to go into shortly, including programs like this from the AIM Living with Melanoma Symposium. Next slide, please. Resources, I'm going to be giving you these. Hopefully these are going to be available and you'll be able to access them. If not, take some quick screenshots. Next slide, please. The ASCO, which is the American Society of Clinical Oncologists publications, I find to be very helpful. They offer basically here a review of what we are currently discussing. I think the long-term side effects portion of this can be useful because the one thing I found doing this is that things are changing so fast, it's extremely difficult to keep up. Next slide. Cancer care has some issues in terms of the guidelines, especially regarding counseling. Support groups can be very helpful. They can be an initial first access in terms of trying to find out how to get set up with this. Next slide, please. The National Cancer Institute publications cover multiple aspects of life after cancer, which you can see here. Very useful. It is all vetted in terms of editorial accuracy, talking about internet resources, and it is a problem, but if you go to these kind of agencies, you can get something that you can believe. Next slide, please. I found this particularly useful. As I think I mentioned, I have multiple cancer survivors in my family, including my wife. We don't talk about support for caregivers very often, but it's pretty important, especially with the elderly who we see. I need to treat the caregiver as well as the patient. Lots of good information here. One of the things that, again, if you're with your primary care provider, if you're the caregiver, you might say, hey, I'm a little burned out. Do you have any advice for me? And they can also help you in that regard. So that's all I have, and I'm glad to answer any questions later. I think I need to turn this back to Dr. Amin or Dr. White.